Welcome back to the House Healthcare Committee. It is 11:15 and we are, as mentioned before, focusing on budgets today. Again, we are doing general overviews. Obviously, we can ask questions, but do know that we will be diving into the recommended policies as well as policies that we all might want to put on the table. So this is going to be a several-week conversation we'll be having. So we have Department of Mental Health with us today. Are we good with technology?
If Claire could send us the link, we will be much better.
Okay, that's great. Yeah. Sure, we'll give you a minute or. You want to start with introducing yourselves?
Sure.
We'll go from there.
Okay. I can go first.
Yeah, sure.
Good morning. Thanks for having us here today. My name is Emily Haas. I'm Commissioner for the Department of Mental Health.
And I'm Allison Crump. I'm the Deputy Commissioner for the Department of Mental Health.
And good morning, I'm Shannon Thompson, the Financial Director for the Department of Mental Health.
Great to have you back.
Okay.
All right. So we have 3 documents from you for those following along. So are we doing the budget request presentation?
Yes.
Okay, great.
So we will start with our framework, which will not be new to this group because we've had an opportunity to explain this about a week or so ago at this point. So as folks are aware, the Department of Mental Health is responsible for providing a system. Let's hold on one second. A system of care for Vermonters to be able to receive care when and where they need and want it. So we've highlighted some of our relationships across that system, and this all falls under some work that we did a couple of years ago for Vision 2030. So all of the things that you see in our initiatives move us towards our Vision 2030. So if we have a chance just to put that up on the screen, you'll see that we have several initiatives that play into this vision of our mental health system for the future. You'll see that we are focused on integration. And you've seen that play out in many of our initiatives and testimony that we've had recently. Incorporating persons with lived experience or peers across our system. And so, and then also more upstream, like our mobile crisis proposals that we'll talk about today. So the Department of Mental Health, we oversee 10 designated agencies, 2 specialized service agencies, and 7 designated hospitals. And I will just clarify what a designated hospital is. A hospital that's been designated by the Department of Mental Health to provide psychiatric care. So those units those hospitals have inpatient units in their facilities. We also operate the Vermont Psychiatric Care Hospital, which is a 25-bed hospital located here in Berlin for adults who are under the care and custody of the commissioner. We also have the Middlesex Therapeutic Community Residence, which will be transitioning into the River Valley Therapeutic Community Residence from 6 to 16 beds. As a department, we have around 250 staff located between 2 facilities and central office. We collaborate with several different organizations, including Vermont Care Partners, the Vermont Federation of Families, Children's Mental Health, the Center for Health and Learning, Vermont Psychiatric Survivors. We're trying and work to collaborate with most folks who will collaborate with us. So. As far as capacity for our system, this re-highlights the pyramid that I showed a couple of weeks ago. So our designated agencies run a mixture of adult crisis beds, adult intensive residential beds, youth crisis beds, Across our designated hospital system, we have beds which are typically deemed as level 1. So those level 1 units are admitting folks who might need additional resources for their stay. A general unit would sort of be the next level down. And then, of course, our children and youth inpatient system, which is currently located with our partners at the Brattleboro Retreat. As you can see, we also partner with to support peer services, and those include 2 adult crisis beds as well as an adult intensive residential. And then again, highlighting the state secure residential River Valley, which will soon be in Essex.
I'm sorry, can you just go back there? I just have a clarifying question. So yesterday we did a field trip to Washington County Mental Health Services, which was really fantastic.
Great.
And some of us got to see one of their peer-run beds. So when you say peer service agencies, would that be an example of what you're saying here, or is that outside of this number?
That would be outside of this number.
Okay.
Were you up on Hebert,
Yeah.
Hebert Street?
No, we were on Berry.
Maple House,
Yeah, great. So yes, that is outside of these. This is operated by Alyssum, located in Rochester. And then also Soteria, which is Pathways.
Great. Okay. Thank you.
Yeah,
So
that's a good clarification.
Another clarifying question, because I have never seen this before. What is Linden Lodge?
Sure.
Sounds nice.
Yes, it's nice. Linden Lodge was a partnership between the state and the Brattleboro Retreat to renovate an existing space on the campus to increase the number of adult beds, adult level 1 beds, so those folks who are needing those additional resources to serve. And that is, I think it's 12 beds and has been online for the last almost 2 years now.
I was going to ask how long that was. I remember seeing that. Okay.
So just making the distinction, the facility that was seen yesterday was a Washington County mental health facility, not a Department of Mental Health facility, which that's the distinction.
Where the Department of Mental Health supports Washington County, and that is a program that they have developed out of that. The peer service agencies with those, the peer respite and the residential are a similar funding model, just to an agency that is peer run. Whereas Washington County Mental Health Services isn't what would be defined as a peer run, but they have peer run programs within them.
Embedded within it, okay, I think I understand.
Such as Maple House.
To follow up on that,
Sure.
so what we saw yesterday in Washington County Mental Health, do you folks run that or control that, or is that outside the scope of what you do? Any of the county,
The designated agencies.
that's a designated agency?
Designated agency,
Oh, okay.
yes.
So, okay,
And so we have
I get you.
provider agreements with each of those agencies that defines the services that they are following.
okay, so these designated agencies are like privately run things that fall under your control?
They're not-for-profit
Right,
agencies that we contract with. They also
yes,
secure contracts with other lines of service, I guess I would call that. So they're doing your adult CRT or community rehabilitation treatment programs, which serve adults with severe and persistent
right,
mental illness. They're also doing some outpatient, adult outpatient, youth outpatient schools.
yes.
And the Department of Mental Health oversees or supports them with almost all of that. But then there are other opportunities to collaborate with, say, the Department of Corrections or Judiciary.
Okay, thank you.
Great.
So that's just our brief snapshot of the system, and we'll move along into our more formal budget presentation. Shannon Thompson, our finance director, will lead that for us. Thank you, Shannon. And she'll take it from here.
Okay, great. Thank you. So this presentation slide here is a summary of our FY24 requests. So this shows you the breakout of the different funding sources and the percents those funding sources hold within the department. On the right-hand side is just a very brief snapshot of the line items and those items that are increases, as well as the items that are initiatives and then decreases on the budget.
And you're gonna go through those
We will
more.
go through all of that, yes. This slide here just shows some breakout of the different programs that we run. This is somewhat a high level of the programs under the children and adult units. So we have Success Beyond 6 at $72 million. The adult services, which includes all of our CRT, our mental health case rate, all of the adult services that we have there. We are showing you the different children's communities, the Middlesex Therapeutic Community Residents, which will be the River Valley Therapeutic Residents. That's their budget there of $8.7 million. VPCH, $30 million, and a few other programs. Mobile Crisis Response, which is a new program we will be talking with you about. Children's PNMI, private non-medical institutions, and then of course admin in general.
May I ask a quick question? When the Secretary's office was in here, they gave us just a very high level. And they had it listed as mobile response, and you have it listed as mobile crisis response. Is that the same thing?
Correct.
Okay, thank you.
Okay, so now we are in the budget request. So that, if you got the talking points, this should be following the talking points and the budget ups and downs spreadsheet. And
That's
some
one
of
of
this is
your-
going to be a summary level in the presentation. And there's more detail.
In the talking points, great.
I see that, great.
So the first item is just our salary and fringe increases for the department. That includes all of the units in the department. So that's $2.3 million or $1.3 million of general fund equivalent. The shift differential changes during the bargaining agreement beginning, I think, July 1. They increased the shift differentials for individuals providing direct care at both the Vermont State Cancer Care Hospital and the Middlesex Therapeutic Residents. So that's that line item.
And that's going, this was what we had talked about before, right? They're going from.
So, yeah, I can talk a little bit about that. So last year we testified around a shift differential related to retention and recruitment. This is separate from that. This was through the collective bargaining agreement for a longer term increase in shift for those folks who are, like Shannon said, providing direct care. So on top of the facility has some folks on 8 hours and some folks on 12 hours. So you will see that individuals who were on second shift, which is our evening shift, they used to get 85 cents extra an hour, and that's moved up to $2, so on and so forth. That helps bring us in line with our neighbor facilities so that there's some equity with the hospital.
Great, thank you.
The next item here is the cost of the impact of retirement increases. That was just has to be broken out, so we'll look at it separately. We also have a line item for overtime at the Vermont Psychiatric Care Hospital and the secure residentials. That is overtime due to the new 12-hour shifts. There is 4 hours of overtime in every 2-week pay period.
And that was related to an agreement with VSEA when we transitioned from 8-hour shifts to 12-hour shifts.
And then another separate line item around salary and fringe is the vacancy savings. We were asked to break that out separately. This vacancy savings number includes a much higher vacancy savings rate for some of our direct care staff due to another line item that we'll be talking about, the travel partners. So that's.
Okay.
RFRs and position classification action requests. So DMH did request some RFRs.
What is an RFR?
An RFR is a request for review, and that's a process when either an employee or a manager can request for a particular position to be reviewed to make sure that it's been classified at the appropriate pay rate. So as in our efforts with retention and recruitment, we did a couple of things. We submitted RFRs for individual positions. And then we also submitted a process called a class action review, which is not a legal review like a lawsuit, which I heard that can be confusing. That's just such language to us that I just want to make sure that that's more of a collective bargaining agreement process of reviewing an entire class of positions. So we did a class action review for our mental health specialist positions, which goes through the process of taking a look at what those positions do and determine if they are evaluated to be paid at the right pay grade. So we did see an increase with that class action review for those for that particular class, mental health specialist, associate, and senior. I think they were increased one pay grade that hadn't been reviewed since 2014. So it is something that we do regularly and should do more regularly to make sure that we're keeping up with those pays next door. So.
Just quick, mental health specialist, what level of education is required for that?
Sure. I don't think it's either a high school diploma and some years experience or full, like several years of experience in human services. Those are the positions that are really doing most of the one-on-one work with individuals who are needing inpatient care or a resident at the secure residential.
So young people, well, high school, well, maybe not young, but.
Yeah, it goes across the age span.
Okay.
We have some folks who have been mental health specialists for over 30 years.
Thank you.
Do those folks get trained?
Yes, they do.
You train them?
We do. We go through a 2-week training that includes crisis intervention, policy procedures,
Sure.
the whole gamut of being able to work with the individuals that we're serving at those facilities.
Okay.
Okay, so the next line item is travel nurse contract increases, $5,656,000. This represents the cost of about 21 travel partners. Throughout the pandemic, we've had anywhere from 26 to 30. And I'll let our commissioner talk a little bit more about that.
No, but what you'll see is us trying to do impact our permanent staff pay to bring us more in line, with the market in Vermont. And then also as those travel nurse contracts start to decrease now that the pandemic we're moving out of our pandemic response, we're seeing those traveler costs start to decrease. And so you'll see some of our initiatives to get permanent staff more adequately paid so that we can close that gap a little bit.
Okay.
Will we be able to see the percent increase overall when we're done from fiscal year 23?
A percent increase between the 23 budget and the 24 budget?
Yeah.
I'll ask Shannon how to should display that.
Sure, so it's going to be a little bit different. It's a little more complicated with our budget this year because we do have additional positions for River Valley. So it's going to look like a large increase. That's actually additional positions. So it would.
Yeah. I mean, overall, when
see.
you're done, will we know? That's, yeah, okay.
Okay.
Contract increases for River Valley. So in fiscal year 23, we have a portion of a year worth of contracts for River Valley. And this is to bring us into a full budget base for FY24. Hopefully we'll be online and soon.
Right, with the new facility. And remind me again, you're starting with moving the Middlesex to River Valley.
Correct,
And not necessarily opening all 16 beds right away.
correct.
Will be a phase in depending on staffing. Okay.
And they've started recruiting for those positions.
Okay.
Which are filling.
Good.
And we're getting ready to, there will, right now, BPCH and MTCR share staff. And so staff will be applying for River Valley so that we can separate those. And so we're still sorting through who will stay on at BPCH and then who will move to River Valley. And then it'll be open up for external applicants.
Okay, great.
So contract increases for the DMH psychiatric services. That contract is currently held by UVMMC. That is potentially going to be changing. So this is a request to increase based on their rates and based on the market rates for psychiatry.
Leslie?
So who would be the alternatives? Changing to what possibility?
Sure, that's a great question. That went out for RFP in November and it just closed this week actually. So we will be reviewing and scoring responses to that. But essentially anyone in or out of state who has the ability to deliver psychiatric services on site there and do on-call and do second certifications, telecertifications for emergency departments, as well as a chief medical officer position there. So it could be any other hospital. It could also be national companies who specialize in staffing hospitals like the Vermont Psychiatric Care Hospital. So we should know shortly.
Can you say how many responses you got, or is that not legit?
Yeah, I think that's posted. I want to say we have 5 responses.
Choices.
Is that right? Oh, you guys aren't on the scoring team. I won't look at you. I believe it's 5 off the top of my head.
But at least you got something, so that's great.
We did.
Yeah. Thank you.
The next line item is IMD investment phase down. This is the phase down of the Institution for Mental Disease funding that is currently funded by Global Commitment Investment and program dollars. We are having to phase that out into the general fund. And I can't remember the final year of that phase out, but I believe it's 25.
I thought it was
27.
27.
later. Yeah.
It's 2027, I believe.
December 31.
By the end of 2020.
And this is a federal requirement.
The federal requirement, because as we're a 25-bed facility, it falls under the Institution for Mental Disease.
So we're keeping the 25 beds. We're just shifting the funding to general fund.
It's just a rename, right? Or it's just a rename in a way? Or, I mean,
No.
25 beds, so I guess I'm not, you could tell me another time.
Okay. We're good?
This one here, the next item is to convert the suicide prevention position and elder care outreach contract from general fund to global commitment investment that is a general fund savings to the state. And we are applying for an investment for all of our suicide prevention activities.
So is this a negotiation item you're doing here with this? Or just you can transfer it or?
We are required to do a request, to fill out a request. I have to be honest with you, I don't know the full process. I just know that we have to fill out a request.
Okay.
Happy to
No,
get
that's
that
fine.
information. Internal service funds, that's just our workers' compensation increases. The next item is mobile crisis response for positions. So the department, in an effort to fully be able to manage the mobile crisis response project, we have requests for 4 positions, and I'll let our commissioner talk a little bit about that.
Sure. So for an example, one of the positions would be State Crisis Program Director. So that position would oversee all of our initiatives that are geared towards crisis programming. So that looks like mobile crisis response. That looks like some of our initiatives related to alternative to EVs, our 988 line. Right now, those programs that are up and running are being managed by several different folks in our department. And so we're adding workloads, and now we need somebody to oversee it in a more succinct way. Anything to add from your lens, Allison?
I think the other positions that you'll see on there is part of what we're aiming for with mobile crisis response is to meet the new Medicaid requirements that allow for us to get more federal match. And to do that, it's really upgrading the way we track and seek data from the services, systems that we don't have, analysis that we can't do currently. So you'll see an analyst in there, as well as someone to monitor all of the compliance that comes with meeting that so that we don't end up with a service that then doesn't draw down the match.
What kind of data are you going to be collecting different than what's collected now by crisis workers?
I can give you a couple examples. So for right now, one of the first questions that came to us when we had a consultant helping us with this is, okay, how often do crisis services go mobile? When the call comes in, how long does it take for them to respond and how far are they going? So similar to what an EMS might track, and their response is sort of here's a map. I got a call at 2:50, I was able to dispatch at 3:10 and it took me 45 minutes to get there. Right now, we don't have the capacity to track those, and that is a requirement for this. So that'd be one example. Another is, was there 2 people present? That's it in this.
2 providers or 2?
There has to be a team of 2. When I say present, one could be via telehealth, but part of meeting this requirement is it has to be a 2-person response team that's available, which is a new thing and not what currently is.
So I'm just gonna say, we're gonna get a lot more information on this. We haven't
Okay, fine.
dived into the policy behind this yet.
Okay,
So
we'll
this
talk more later.
is high level budget, and then we'll go into the policy. We'll have them back to talk about that specifically.
Yes, and we've kind of outlined all of the positions with the responsibilities in the talking points.
Great.
So then we just have operating increases again to support River Valley, just to fully annualize the operating expenses for that facility.
But just for the beds that you're opening, not for all 16 beds, right? So once you get to the point where you want to add more beds, there'll be an additional budget ask, or would this?
This anticipates all 16
It does,
beds being
okay.
online beginning
Great.
July 1.
Okay,
I'm not sure if that's going to
happen or not, but okay,
but this is our base budget request, basically,
great.
that facility. The next line item is internal service funds, and I've broken out the different funding for each line item there. These are all, I'm sure you're going to see these in all of the budgets. Fee for Space, ADS, which is our IT department, Human Resources, the Vision Accounting System. So these are all costs associated with those things. We have a couple of transfers here, transfer of funding to DIVA for CRT Dental. So this is a new Medicaid service, or it's in some cases, I think, a new Medicaid service, but also an increase to fully pay for certain items like dentures. We typically pay now with a special fund that we have set aside for that. So this is just moving the money to DIVA, and they will be able to bill DIVA directly for these services.
CRT?
Yes.
Community rehabilitation treatment.
Oh, my apologies. I do need to spell that out for you. I can do that. The next line item is our private non-medical institution increase, and this is an inflationary increase to the PNMI facilities while the agency engages in a cross-departmental discussion to adequately address the needs.
Can you give an example of one of the PNMI, so we, like a name behind it, so we can make sure we understand what that is?
Yeah, so I'm not so familiar with the names of the facilities.
Okay.
I do know one of them is Jared House with the Howard Center. I think that's more crisis beds, but it's under the PNMI rate structure.
I just want to add, we have a place called Serenity House in Wallingford.
that one?
It might be, I don't know. but
I don't think that, that's a
It's not
substance
mental
use,
health,
yeah.
it's substance abuse.
I believe
Okay.
those are
See some
through
shaking
our,
hands.
partners at the Vermont Department
Okay.
of Health, yeah.
Then we have Washington County Mental Health for residential increase. That's a targeted increase to support salaries at that facility. They have struggled with staffing challenges, so this is to increase those salaries.
We did hear about that yesterday, so great.
This is another fund transfer from DCF because this is a partnership with DCF and DMH. So DCF will also fund those increases. DMH pays for those under our mental health case rate for children. So DCF is supporting that as well.
Okay. Art?
You just have a general question on these. You show them as BAA items now, so they're in the BAA?
Yes.
And they're now a budget increase too.
That is correct. I was told that we needed to notify you if an item in the base budget request was also a request in the BAA. So that's just a note to let you know that we also have a request in the BAA.
So if the BAA is approved, that doesn't take this away.
No, it's not, because BAA is not your base budget. This is your base budget request. So now if you approve this, we will always have this money in the base budget to support this. Okay.
Thank you.
So this is maintain 988 suicide prevention line. This is additional funding needed to maintain that line. We have two agencies, Northeast Kingdom Human Services and NCSS, that are our current 988 agencies. And then this next line item is to move the suicide prevention activities around 988 from general fund to global commitment investment. Again, it's that investment that we are applying for around the suicide prevention. Clara Martin Service Point. This is something that has been funded through our block grant, and it's no longer eligible for block grant funding. I'll let our commissioner talk a little bit more.
I was gonna say, I don't think we've ever heard about this.
Yeah. So this is a program that collects federally required data for our PATH report, but I cannot remember for the life of me today what PATH is supposed to spell out. So we will get that back to you. But Clara Martin Center, the designated agency in Randolph and Bradford, operate that data collection for that grant, which is focused on housing.
Okay.
Unless you know what PATH spells out.
I know the last word is housing.
You can spell that for you. You can tell. Okay. Next line item is converting, again, suicide prevention funding. We had it in several different places, so this is all part of that investment.
Okay.
Converting pathway support line from general fund to global commitment. The other investment that we are requesting is for peer services for some of these peer service grants that Commissioner Haas was speaking about earlier. Alyssum, Pathways, the way. We are converting those to global commitment investment. Receiving funds, I skipped one. Transferring funds to DCF for NFI room and board. That is, Medicaid does not pay for room and board, and the facilities that we pay for at NFI are under the mental health case rate. We need to pull the room and board funding out of that and pay for it in a different way using general fund. So we pull that out of the mental health case rate, and we're sending the money back to DCF so that each department can pay the associated room and board for the children that are under their custody and care.
Okay.
Receiving funds from DCF for CSAC. This is another collaboration that we've had with DCF under the IFS program.
Integrating family
Thank
services.
you, and I'll let our deputy commissioner talk a little bit more about that.
Yeah, this is Integrating Family Services has been a partnership where DCF has contributed funds to allow for youth who are in DCF custody to be served in a bundled way versus siloing the funding. So this is them continuing to support that.
Expanding mobile crisis response. So this is the funding that's necessary for another partial expansion. This is not the full expansion to 10 units for the entire year. This is another rollout. We currently have funding in our FY23 budget for the 5 locations, and we are expanding as we think that we'll be able to get those online.
And does this tie back to the 4 positions?
It does. Yes.
So we will definitely have you come back in and talk about that.
Yeah.
Okay, peer support credentialing. This is a request. So Vermont is one of only 2 states that doesn't have Medicaid coverage for peer supports. In order to receive Medicaid reimbursement, we must have a credentialing process. And I'll let our commissioner or deputy talk a little bit more about that if you'd like.
This is continuing efforts from last year related to moving towards a credentialing process for peers, individuals with lived experience to deliver care and have an opportunity to A, be credentialed and B, bill Medicaid.
So my understanding is there, if I'm correct, remembering from last year, which seems like a long time ago, there was a grant that facilitated a working group to determine what we should be doing. And so is there a report coming out or?
There is.
Okay.
I believe we get that this week. I'm anticipating we'll receive that shortly.
Okay.
And that was cross-stakeholder engagement, included the Office of Professional Regulation into those conversations. And so we're anticipating those results from that stakeholder group.
Okay. So we'll have to have everyone back in on that too. Okay. Great.
And the last line item I will let our commissioner talk about as well. That's the therapeutic alternatives for emergency departments or emergency departments in the Northeast.
I'm actually going to let Allison talk about that.
So Alternatives to Emergency Departments is an initiative we've been very interested in. We put out a request for proposals. This particular region had the highest rate of use of emergency department for those in mental health crisis. So if you're in mental health crisis in the Northeast Kingdom, you're much more likely to be seen in an emergency department. There's been a real push to provide more services in that region. And so this initiative was pulled out for this budget to support a proposal that they've done in partnership with NVRH, the regional hospital up there, as well as their police, and to have a space for people to go who might be in mental health crisis. That's not the emergency department.
Great. So I think we'll want to hear more about that as well. Great.
And this is mobile crisis response, which we have talked about. I don't know if we want to go through this again, but basically we do have an RFP that's been out for mobile crisis. We have responses and we're reviewing them now. And we are hoping to arrive at someone to select who can provide the service, to then draw down that 85% match.
So all of the budget items that are tied to an RFP, are we anticipating those RFPs will be decided before we have to decide on a budget?
That's a good question. We will get back to you because I think there are some complications. It's not clear for each one. So I think we can tie each existing RFP back. Because like we did RFPs for alternatives to EDs, but there was also already money attached to that.
Okay.
So we can figure out a way to display that so it's more concrete.
When we talk about each one, it'll just be helpful to
Yes.
know where we stand in the process.
Absolutely.
Determine allocation of the money,
Yeah, that makes sense.
appropriation of the money, I should say. Okay,
Lori?
yes.
How many mobile crisis centers are we trying to turn up this year? We have,
Sure,
uh,
go ahead.
proof of that?
It depends on what you mean by center. And so what we are trying to do is it takes a lot of infrastructure to stand up something that has a full administrative oversight. So what we don't want in a state the size of Vermont is 5 different, I'll call them companies, coming in and running 5 different mobile response units. A state like Massachusetts has 6 total, programs that would serve the entire state. So for Vermont, that's a lot of administrative oversight for a small state. And our consultants have let us know that we don't have enough staffing in the state. So we are looking to push, we put out in our RFP for 5 or less to respond. And so that was kind of the
Okay,
max.
so these are contractors.
Right, we'll be
You
exactly.
contract this out?
Mhm.
Oh.
Yeah.
So the one in Rutland's run by a contractor?
Well, it happened to be that the entity we're contracting with is the designated agency in that case. And so designated agencies are a valid possibility for this.
Okay.
But
They would
just
have to
wouldn't
bid on it.
necessarily stand up 10 separate units to do
Right.
this work.
Okay.
They may contract out with those regions to deploy people from those regions.
Are you specifying where you want them in the RFP?
We're looking for statewide. And so
Okay.
basically we're asking for collaboration.
Thank you.
And then one of the things we wanted to highlight for you all, because obviously a budget sends a message about what priorities are, is that there was a lot of federal funding opportunities this past couple of years. And so we have taken a lot of those federal funding opportunities and put them in places that might be of interest to the committee to understand why some things might not be on our budget list. And so this was to highlight, I won't go through them all in detail, but just to give you a sense of what's been provided for community investments for stabilization to designated agencies, for identifying gaps in the system or places where our stakeholders have said we really want this. And so an example is alternatives to emergency departments. We've heard a lot about wanting a type of mental health urgent care like you'll see at the Northeast Kingdom. So we have $6 million there. It just happens to be through a federal opportunity that's funding that. And then some other programs involving community justice reinvestments, housing grants. We've got $4 million of housing grants going out to designated agencies and special services agencies. We have a provider wellness program happening for first responders. And then on the next one, I'll just highlight a couple pieces. Obviously, being culturally responsive is going to be a huge piece of this work, and we've got a long ways to go. And so we're leveraging federal opportunities to provide some funding there for community liaisons. We also were able to fund case managers for provide funding to each of the designated agencies for an additional case manager that sort of talked about, we know there's been more need for COVID response. And so in response to that, that's what that funding went for. And then some mental health language access videos and specific outreach to the Abenaki community and their sects and tribes.
So I feel like some of these are familiar, so I believe some of them were part of the legislation we passed just last biennium using ARPA funding. We've had Agency of Human Services come in and talk about some of the nursing-related workforce programs we set up, and disappointingly, the money is very slow to get out the door for many reasons, most of them being the federal requirements. I'm curious, is the money out the door on these ARPA funds? Is there any issues we need to know of?
Yeah, I can tell you, for example, the housing funding, we had $4 million. We spent $3.2 million of it. So there are a few, I'm told, contracts that aren't fully spent yet. But for the initial, biggest bucket there, the $14 million, there was $2 million that was available. It was pretty close to $2 million that went out the door. I can get you that number. And then the premium pay, it was $12 million that was spent.
Okay, so it would be helpful just to have a quick, what was spent, what's left over, what's the plans with what's left over? Are there any timing deadlines that we need to know about? That would be very helpful. Okay, thank you.
And then I hear we're coming back next week to talk to you about suicide prevention. I'll hit the highlights. I know obviously we knew that there was an increase last year, an unprecedented amount of 142 Vermonters lost to suicide. And I know this committee was interested in how things look today. And so the next slide will show you where we're at with that. We are currently higher than the 3-year average, but not currently higher than we were last year. We anticipate by the end of this year, we will still be higher than the 3-year average. We're hoping that it won't be as intensive as it was of a loss in 2022.
And we're still waiting on November and December.
Still waiting on November and December.
Can I ask a question? Do you gather data on method?
We do. So next week, you'll get a very,
Okay.
VH has done an impressive job
I was
of
wondering where we need to put our,
methods, demographics, ages,
Yeah,
genders.
good.
Yes.
The end of next week, we will be spending quite a bit of time on suicide prevention.
Thank you.
And then we're assuming it's of the committee's interest to understand how well this money is spent and how we account for it.
We are.
Assumption.
Yes. So we thought we'd give you a little taste of this, and this slide is just to let you know that if you want to really dig in on things, these links are active and you can go in and see scorecards. First, I think this chart really tells a story. And so what you're looking at here is our kind of main core programs that the designated agencies provide. So we have at the bottom in yellow, your CRT, that's the term you've heard, community rehabilitative treatment. That's for our adults with severe and persistent mental illness. At the top in the light blue, you'll see our children and youth. That's the number of children and youth served in the year. And then dark blue is outpatient. That means, your therapy, your once a week coming in for group or individual therapy. Emergency services is the red. Those are teams that serve people who are in mental health crisis. And if you've had any of them come in, or if you've talked to Representative Gina over here, you'll hear that they're very busy, and this shows that. And so I think one of the things that we're looking at with that red line increasing is what services can we invest in that are going to help that increase? So that's one of the things we're looking at through mental health urgent cares, just trying to find an efficient way to serve people in the right setting. And then the other is mobile crisis response, which is a service that's intended to be going out ahead of, say, somebody needing to go inpatient. So right now, our emergency services are doing the very best they can to serve people who need to go inpatient. Mobile response is hopefully getting to people sooner.
So this obviously shows the numbers that are served. Is there any understanding by either wait list or some other method of how many we're not able to serve within our system of care?
Right now, we don't have a great way of accurately depicting that besides anecdotally. So we know from the narrative and qualitative data. We can show you, and what we'll show you on the next slides is access, which is a proxy. If it takes you 3 weeks to get in somewhere or 6 months to get in somewhere, the assumption is that a lot of people are waiting. But we don't have a way to track everybody who called and then hung up when they found out that they couldn't.
Listen.
I'm wondering about school-based services, which are a really important part of what you do. And what happens in the off-season, off-school? What happens to these kids?
Yeah, we have some really, I think, fascinating data on school mental health. And there's only a couple slides here. It'll be the last 3. Most programs do serve children and youth during the school year. It just looks different. So there'll be programs, either summer camp programs that offer or a way to go to the home to provide services in the home over the
So
summer.
it is continuing. I just worry about all of a sudden it ends.
There are community mental health agencies. If you're involved in Success Beyond 6, there's a pretty good system to hold you through.
Thank you.
This is the Success Beyond 6 data. And so I will just highlight for you all that this is through the Child and Adolescent Needs and Strengths Assessment tool. That's been a new tool that just looks at what are the needs and strengths of kids being served in our school mental health programs. And these are specifically school mental health programs that the DAs provide through Success Beyond 6. What you're seeing here is they are assessed every 6 months for the school programs. We set that up to be fall and spring. And so we're looking at what are the needs of youth coming into those programs and how are we impacting them over time. In the year that we're looking at in FY 2021, we'll have FY 22 data fully soon. We've seen an increase in anxiety, not terribly surprising. And we have issues of attention deficit, depression, and anger control. The good news is we are impacting those and we're seeing a decrease. And what this measures is if the need was resolved, meaning that it is no longer something that would be on a treatment plan or need to be addressed. Even though eating disorder looks small over there in the corner, highlight, it has gone up significantly since the past few years. It used to be very, very tiny, and we've seen an uptick in that. There's just a couple other highlights with this data that I think tells us a little something. There's a risk domain on this tool, and it measures all the things on this list. So suicidal ideation, self-harm, so your cutting behavior, sexually problematic behaviors, runaway, delinquency. Over the years since we started using this tool, it's always been suicidal behavior and self-harm that have been most prevalent. This is the first year where danger to others has topped the list and all of a sudden shot up. Danger to others mean you're doing some kind of behavior that is harmful to others, whether that be hitting or, a lot of the behaviors that we've seen in the news in school. So we're seeing that tick up. We're also encouraged to see that if you're in this program and these types of services, you're seeing those behaviors reduce pretty significantly over time. And then the last one is life functioning. And that one also was notable since the pandemic. We've always seen a high need for family issues. Family discord means you have some kind of issue in your family that's causing you distress at school. That has always been high, as has school behavior, but sleep has increased as a need over the past couple of years. And this is the first year that school achievement has beat out any of the other issues.
What is that? School achievement?
School achievement means you have a need for school achievement if you are one or more years behind grade level.
Wow.
So that's the way that we're now able to look at those programs and see what the needs are, how they're doing.
Can we go back? I want to not skip over the other, we have a couple minutes. The how well are we doing access to care? Can we just go through this?
This access to care measure does have a high bar. It's what percentage of people who, when they called and said, I need a service, were offered a service, a first appointment within 5 calendar days. So we pre-COVID had agreed on this as being the bar, and we're seeing agencies, there was some uptick in it, and then with the staffing crisis, we're seeing it start to go down. Something that we're monitoring closely. But one important thing on this next slide is we measure access in 2 ways, because it's one thing to get your first appointment. It's kind of like really great if you call and they say, we can see you today, but then they just gather your information and you're on a wait list for 6 months. And that's something the agencies have been really trying to help keep people stay engaged and bring them in sooner. So this measures how many of them were actually seen for whatever treatment was recommended within 14 days of that first appointment. So that one is a little bit better than the 5-day one, and we're hoping to see that increase back up once we get staffing stabilized.
Okay.
This is, we applied that tool that I just showed you the data for. It's called the CAMS, the Child and Adolescent Needs and Strengths. And to get good data on the population, you need the tool to actually be used. So this is us tracking agencies' ability to get the tool and apply it to their population. And they've been able to increase to get around 81% of children you served have gotten a CAMS, which is pretty good.
Yeah. So before we go into the Vermont Psychiatric Care Hospital, do we have the ability to measure this data against organizations in other states, mental health units and departments in other states, and national data? I mean, so we have this, which is great, but we don't, is this good or is it not?
So one of the things that we're doing is right now, the benchmarking we have for these measures is just against ourselves. So, which is an okay way to do it. We chose the access measures because it was something 5 days, the 5-day measure, for example, was something already required by CIS programming.
CIS is
Children's Integrated Services. Yes, it's for the younger youth. And so it was something that existed in Vermont that providers already had to adhere to. It was also part of the Centers of Excellence, which Vermont Care Partners had pulled together and sort of done a peer-driven, how do we want to assess our services? And so to start us off, the state has partnered with existing measures.
Okay.
We're now looking at what's national and what's benchmarkable. The problem is sometimes we find our population served is so small that doesn't always tell a great story when we're putting ourselves on
Various others. Okay.
And this one is we've, over the past decade, been really taking a look at how well we do with least restrictive care in our inpatient settings. And around the time of, you'll see this chart dip down, it was around the time we employed 6 core strategies. What we're talking about here is seclusion and restraint. And so in inpatient hospitals, and knowing Emily's looking at me while I'm talking about this, I'll try to get it right. In inpatient hospitals, we're looking for that to decrease. So 6 core strategies trains you how to intervene with folks without having to do something. And we saw that decrease going down. What we're monitoring now is with more travelers and with more turnover in inpatient settings creates more risk for interventions that we're trying to avoid. And so we've seen a little bit of an uptick, and it's something that we're monitoring closely.
We can compare nationally for these, and Vermont as a state historically has very low seclusion and restraint hours in general. And so we do see a little bit of a tick here. I think there's complexities in there with increased travelers and also a lower census. So there could be maybe only 16 or 20 folks going into that data versus 25 when we're at full capacity. And so all of our hospitals are trying to figure out that sweet spot of having to, you want to keep as many beds online, but you don't want to risk the quality of care you're delivering.
Thank you very much. Brian, and then that'll be it.
So you spoke about, you highlighted the increased violence towards others that we're seeing as a behavior. And we looked at the beds in the system and level 1 beds at the beginning. And I waited till the end to ask this question because I wanted to make sure that it didn't come up otherwise. But it seems as if there's like an increase in violence in healthcare settings. And then what happens is there's nowhere a person can go that can really manage the behavior. And like, just to be really specific, like as an example, because then I'll ask the question. When I was a student intern in the Lott Psychiatric Unit at UVM Medical Center, I think it was called Fletcher Allen Healthcare at the time, honestly. And like they, when someone was violent, they would go to the state hospital. And then Irene happened, and there's like the state hospital washed away or flooded, and now there's what I'm hearing from the hospital, from University Medical Center, is that when a patient's at that level of violence, there's nowhere to go. And so they're containing, or we, I should say, because I'm part of the staff, we're containing people in like tiny rooms in an emergency room where you've got like security guards and nurses and social workers in this cluster, like with a person like barricaded in a room, like, with nothing in the room. Like, it's like the most inhumane situation for everyone involved, and there's nowhere for them to go. Has the state considered the idea of maybe creating a new kind of bed that's like above level 1, like level 0 or something? I don't know, like a place where people can go in Vermont when they're at the most violent, where they could be safely contained and get treatment and not just like languish in a cell, while staff are being hurt and abused by them. And while they're hurting themselves too, like people are hurt, don't get me wrong, people are hurting themselves too. So I don't know. I know that was a lot, but I don't think people really understand how grim it actually is when you're in that situation. And it feels like hopeless for the staff, I can say, from my own personal experience, when there's nothing you can do for a person.
It's scary for his other patients.
Yes, that's a whole other thing. Like if there's children or others nearby, there's just vicarious trauma all around. So, but the question though is, has the state considered this? Like, for example, at the state hospital, the possibility of maybe creating a wing or similar. I think you mentioned that Brattleboro did. They created like Linden House, like
And Linden Lodge is just a continuance of the beds that they have on T4, which are similar to the Vermont Psychiatric Care Hospital. I would say the answer is no, we're not looking at even more beds that are addressing acuity. That's why you're seeing our initiatives trying to serve folks before they get to that point. I'd also like to clarify, violence can look different depending on the individual in front of you, and it is not always as a result of mental illness. And so we want to make sure that we are assessing folks appropriately and not continuing that myth that violence equals mental illness. Most, in reality, individuals with mental illness or experiencing mental health challenges are at more risk to be a victim of said violence. And so I think we need to have more discussion about that. It's not necessarily about putting somebody in the highest level of care and locking them up.
I guess the question, and this is like a question we can come back to, is
Sure.
if an assessment is done and it's determined that a person's violent behavior is not due to a mental health or substance abuse issue, then why are they being violent and what do we do about it? You don't have to answer that. I think
Yeah.
we need to figure that out. Like,
No, I think
you know.
all of healthcare needs to
Yeah.
figure that out. And I know that there is some pending legislation right now that I haven't gotten a chance to unpack yet related to assault on healthcare workers. And so you're right, we need to talk more about that. But I don't want to confuse that necessarily with individuals who have a mental illness.
Thank you for that. All right, we're not past our time because we were going to 12:15, but I'm sure everyone's hungry. Thank you very much. And we'll see you next week and probably the week after that. So
Thank you.
have a great day. Claire, we go up here.